Assalamu alaikum. I'm Dr. Isra Ali. Our lecture is Pathology of Female Genital Tract, Body of Uterus. Our objectives are outline disorders of uterus, including discussion of endometritis, acute and chronic, define adenomyosis, and describe the pathological features, gross and microscopical features, define endometriosis, state the theories that explain the origin of these lesions, and describe the pathological features, gross and microscopical features. Also, in our objectives, we will define endometrial hyperplasia, state the classification of hyperplasia, causes, and discuss the pathological features. We have also listing the most common neoplasm of the body of the uterus, including endometrium and myometrium of uterus. We will discuss the most common benign tumors of myometrium, leiomyoma, their frequency and pathological features, which means the gross and microscopical features. Finally, discuss endometrial carcinoma, including epidemiology, pathogenesis, risk factors, and pathological features, the gross and microscopical features. Endometritis, inflammation of endometrium. This may be associated with retained products of conception subsequent to miscarriage or delivery, or a foreign body such as an intrauterine device. Retained tissues or foreign bodies act as a nidus for infection, frequently by flora ascending from the vaginal or anal region. Notice, all forms of endometritis may present with menstrual abnormalities, infertility, and ectopic pregnancy due to extension of the damaging inflammation to the fallopian tubes. يعني endometritis, inflammation of endometrium, may ascend to fallopian tubes, inflammation يؤدي إلى fibrosis, adhesions, وبالتالي lead to infertility and ectopic pregnancy as well as menstrual abnormalities. Also, نقطة مهمة نتذكرها إنه acute endometritis is frequently due to Neisseria gonorrhea or Chlamydia trachomatis. This is the microscopical picture of chronic endometritis. As you see, there is a large number of plasma cells. شوفوا احنا مقشريها بالأرز. هاي كلها هي plasma cells within the stroma of endometrium due to chronic endometritis. Adenomyosis. This refers to the invagination of the stratum basalis of endometrium down into the myometrium. Nests of endometrial stroma, glands, or both are found well down in the myometrium between the muscle bundles. The latter become hypertrophied, so the uterus is enlarged and globular. مثل ما قلنا الانفاجينيشن هو of the stratum basalis of endometrium. So this is the non-functional layer. فما راح يكون هناك cyclical changes or bleeding. Because these glands derive from the stratum basalis, they do not undergo cyclical bleeding. Nevertheless, marked adenomyosis may produce menorrhagia, dysmenorrhea, and pelvic pain before the onset of menstruation. This is the gross appearance of the uterus with adenomyosis. The wall is irregularly thickened مثل ما تشوفون قدامكم. It contains small hemorrhagic foci. الأرو مأشر على هاي المنطقة اللي بيها hemorrhagic foci. The other gross appearance show thickened and spongy appearing myometrial wall of this sectioned uterus. This is typical of adenomyosis. أيضا أكو عندنا small white leiomyoma at the top. This is the microscopical picture of adenomyosis of uterus. We see the endometrial glands and stroma invaginated in myometrium. يعني أنا لما أجي أفحص بالميكروسكوب بالهاي باور فيلد حتى أقول this is definitely adenomyosis of uterus, أتحرك 3 مرات بالهاي باور فيلد from the surface of endometrium down into myometrium حتى أقول this is the diagnosis of adenomyosis of uterus، لأنه أحيانا قد يكون cross section ونشوفه within the myometrium، بس بهالطريقة this is a definite diagnosis of adenomyosis of uterus. Now we will talk about endometriosis. This is characterized by the presence of endometrial glands and stroma in a location outside the endomyometrium، يعني outside the uterus. It occurs in as many as 10% of women in their reproductive years and in nearly half of women with infertility. إذا ننتبه إنه half of women with infertility ممكن إنه نشوف بيهم endometriosis. It may present as a pelvic mass filled with degenerating blood، نسميها chocolate cyst. It is frequently multifocal and may involve any tissue in the pelvis, ovaries, pouch of Douglas, uterine ligaments, tubes, and rectovaginal septum. This is the microscopical picture of endometriosis. In A, we see endometriosis is present in the mucosa of colon. شوفوا هاي الميكوزا of colon. Here is endometrial tissue, endometrial glands and stroma. So this is endometriosis present in the mucosa of colon. And in B, higher magnification revealing the presence of both endometrial glands and stroma. There are 3 possibilities have been suggested to explain the origin of these lesions. عندنا 3 theories. First, the regurgitation theory, currently the most accepted, proposes menstrual backflow through the fallopian tubes with subsequent implantation. فنخلي بالنا انه هذه regurgitation theory هي currently the most accepted theory. The second theory is the metaplastic theory, proposes endometrial differentiation of coelomic epithelium. Third theory is the vascular or lymphatic dissemination theory, has been raised to explain extrapelvic endometriosis. Endometriosis usually contains functioning endometrium، فننتبه انه بالاندومتريوسيس هو functioning endometrium، بينما قبل قليل قلنا انه الادينوميوسيس يحوي على non functioning endometrium لانه from stratum basalis، while endometriosis usually contains functioning endometrium which undergoes cyclic bleeding, thus appearing grossly as red-blue to yellow-brown nodules due to collected blood. When the ovaries are involved, the lesions may form large blood-filled cysts that are transformed into so-called chocolate cysts as the blood ages, so it will appear as a chocolate cyst. Seepage and organization of the blood leads to widespread fibrosis, adherence of the pelvic structures, sealing of the tubal fimbriated ends, and distortion of the oviducts and ovaries. This is the gross appearance of endometriosis of the ovary. On the left, we see this is a section through an enlarged 12 cm ovary, demonstrate a cystic cavity filled with old blood, typical for endometriosis with the formation of endometriotic or chocolate cyst. فهذا هو appearance of the chocolate cyst. On the right, the gross appearance show inner surface of cyst. In case of ovarian endometriosis, the color is typically brown because it is older. Regarding the microscopical features of endometriosis, the histologic diagnosis depend on finding 2 of the following 3 features within the lesions. Number 1, endometrial glands. Number 2, endometrial stroma. Number 3, hemosiderin pigment. So any 2 of these 3 features, if available, the diagnosis will be done, that is endometriosis. Extensive scarring of the oviducts and ovaries often causes sterility. Pain on defecation reflects rectal wall involvement. and dyspareunia, which means painful intercourse, and dysuria reflect involvement of the uterine and the bladder serosa respectively. In almost all cases, there is severe dysmenorrhea and pelvic pain as a result of intrapelvic bleeding and periuterine adhesions. This is the microscopical appearance of endometriosis of the ovary. In ovarian endometriosis, as we see, in this area endometrial tissue reproduce the appearance of normal endometrium. فنشوف أمامنا أكو endometrial glands and stroma overlying the ovarian tissue. فلما عندنا two criteria اللي هي endometrial glands and stroma هاي يحقق diagnosis of endometriosis as we said in the previous slide. Also we have collection of the hemosiderin-laden macrophages histiocytes below the endometrial epithelium مثل ما تشوفون أمامكم, وبالتالي this is endometriosis of ovary. Endometrial hyperplasia. This is an exaggerated endometrial proliferation induced by sufficiently prolonged excess of estrogen relative to progestin. The severity of hyperplasia is classified according to two parameters: A. Architectural crowding of the glands. B. Cytologic atypia. الاركيتكتشرال crowding of the glands اللي هو ممكن نشوفه من low power. الcytologic atypia هو structural abnormalities اللي نشوفها بالسيل من ننزل عليها بالhigh power field. Accordingly there are three categories. راح يصير عندنا three categories اللي هي 1. Simple hyperplasia, 2. Complex hyperplasia, and 3. Atypical hyperplasia اللي هي most serious. These three categories represent a spectrum based on the level and the duration of the estrogen excess. The risk of developing carcinoma depends on the severity of hyperplastic changes and associated cellular atypia. هاي كلش ننتبه عليها cellular atypia. So simple hyperplasia carries a negligible risk, while a woman with atypical hyperplasia has a 20% risk of developing endometrial carcinoma. فننتبه أنه نسبة لا يستهان بها 20% من atypical hyperplasia عندهم risk of developing endometrial carcinoma. Thus, when atypical hyperplasia is discovered, it must be carefully evaluated for the presence of cancer and must be monitored by repeated endometrial biopsy. فإحنا لما نكون عندنا case with atypical hyperplasia بالmicroscopical examination نسوي scanning و screening لكل الفراغمنتس الموجودة لا يكون أكو in the nearby area any area of CA near the atypical hyperplasia أو arise from the atypical hyperplasia. Any estrogen excess may lead to hyperplasia. Potential contributors include: first, we have failure of ovulation, for example around the menopause. Second, prolonged administration of estrogenic steroid. Third, estrogen producing ovarian lesion such as polycystic ovary اللي نسميه ستين-ليفنثال syndrome، أو ممكن إنه estrogen producing ovarian tumor مثل granulosa cell tumor. The fourth point هي obesity, because adipose tissue processes steroid precursors into estrogen. Gross features: in simple hyperplasia, the endometrium is diffusely thickened, while in complex and atypical hyperplasia, there is usually focal thickening of the endometrium. For the microscopical features, simple hyperplasia involves both the glands and stroma. The normal gland to stroma ratio is maintained. The glands are proliferative and some are cystically dilated. فنشوف increase بالnumber of the glands and the stroma، وبالتالي تبقى الراتيو normal. ممكن أيضا قلنا نشوف إنه cystically dilated glands سنشوفها بعد شوية microscopically. In complex hyperplasia, there is glandular crowding with little stroma separating the proliferative glands. typically this is focal process. فهنا راح نشوف انه الجلانز زيادة بالنمبر مقارنة بالستروما and this is focal نتذكر. Simple and complex hyperplasia are further divided into atypical and non-typical. Atypical hyperplasia characterized by atypical nuclei of the proliferative glands as evidenced by nuclear stratification, nuclear rounding, and the presence of nucleoli. This is diffuse endometrial hyperplasia. As you see, there are prominent thickened folds of endometrium in this uterus, which is open to reveal the endometrial cavity. These are an example of hyperplasia. This is the microscopical picture of complex endometrial hyperplasia without atypia. In A, you see closely packed endometrial glands with irregular distribution separated by abundant endometrial stroma. In B, which is at higher power, the glands are lined by proliferative type endometrial epithelium without atypia. As you see in the center of the microscopical picture of B, the glands are arranged back to back. We name it back to back, which is a feature of complex hyperplasia. So this is complex endometrial hyperplasia without atypia. This is the microscopical picture of atypical endometrial hyperplasia. As you see, the nuclear and cytoplasmic differences are present between atypical glands at the upper right and residual normal endometrial glands in the center. فواضح مثل ما تشوفون انه الاتيبيكال endometrial glands show increase بالNC ratio, hyperchromasia, pleomorphism, multilayering نشوفها بالglands اللي هي atypical endometrial hyperplastic glands at the upper right, while the normal endometrial glands in the center يشوفون اللايننج عندنا عبارة عن single layer of lining epithelium, no pleomorphism, no high NC ratio, normal appearance of these glands. Tumors of the endometrium and myometrium. The most common neoplasms of the body of the uterus are: first, endometrial polyps; second, smooth muscle tumors; third, endometrial carcinomas. All tend to produce bleeding from the uterus as the earliest manifestation. Leiomyomas are benign tumors that arise from the smooth muscle cells in the myometrium. Because of their firmness, they are also called fibroids. ولذلك احنا معتادين على تسميتها بالفايبرويدز. They are the most common benign tumor in females and are found in 30 to 50% of women during reproductive life. So remember, they are the most common benign tumor in female. Estrogens and possibly oral contraceptives stimulate their growth. Conversely, they shrink postmenopausally because estrogen become low. Gross features: they are sharply circumscribed, firm gray-white masses with a characteristic whorled cut surface. They may occur singly, but are often multiple tumors scattered within the uterus, ranging in size from small seedings to massive neoplasms that dwarf the size of the uterus. Some are embedded within the myometrium. We call it intramural, whereas others may lie directly beneath the endometrium, called submucosal, or directly beneath the serosa, called subserosal. Larger neoplasms may show foci of ischemic necrosis with areas of hemorrhage and cystic softening. We call it red degeneration. After menopause, they may become densely collagenous and even calcified. This is the gross appearance of leiomyoma of uterus. As you see at the upper photo, there is markedly distorted uterine corpus with multiple irregular masses protruding from its surface. These are subserosal leiomyoma. We call it subserosal leiomyomata. On the lower photo, you see the uterus has been opened, revealing several large masses that protrude from under the endometrial mucosa. we call it submucosa. There are also intramural and subserosal examples. One of the submucosal tumor is in the form of pedunculated polyp that has protruded through the cervix. This is another gross appearance of leiomyoma of uterus. Smooth muscle tumors of the uterus are often multiple, seen here as submucosal, intramural, and subserosal leiomyomata of the uterus. Microscopical features of leiomyoma: there are whirling bundles of smooth muscle cells, foci of fibrosis, calcification, ischemic necrosis, cystic degeneration, and hemorrhage may be present. Leiomyomas of the uterus may be entirely asymptomatic and be discovered only on routine pelvic examination or imaging studies. The most frequent manifestation when present is menorrhagia. Large masses in the pelvic region may become palpable or may produce a dragging sensation. We should remember benign leiomyoma rarely transform into sarcoma. This is the microscopical picture of leiomyoma uteri. Here is the microscopical appearance of a benign leiomyoma. Normal myometrium is at the left, and the neoplasm is well differentiated so that the leiomyoma at the right hardly appears different. Bundles of smooth muscle are interlacing in the tumor mass. Endometrial carcinoma. After the dramatic drop in the incidence of cervical carcinoma, endometrial carcinoma is currently the most frequent cancer occurring in the female genital tract. فننتبه أنه الendometrial carcinoma is currently the most frequent cancer. Epidemiology and pathogenesis. Endometrial carcinoma appears most frequently around the age of 60 years. There are two clinico-pathological settings in which endometrial carcinomas arise. First, in perimenopausal women with estrogen excess, these are of endometrioid type. Second, in older women with endometrial atrophy, these are of serous type. So remember, we have endometrioid type in perimenopausal women and serous type in older women with endometrial atrophy. Well-defined risk factors for endometrioid carcinoma include: A. Obesity associated with increased synthesis of estrogens in fat depots. B. Diabetes. C. Hypertension. D. Infertility. Women tend to be nulliparous, often with anovulatory cycles. فنشوف انه معظم الريسك فاكتورز هي الريسك فاكتورز اللي بالاندومتريال هايبربليجيا هي نفسها الريسك فاكتورز of endometrioid carcinoma. At least some of these risk factors point to increased estrogen stimulation, and indeed it is well recognized that prolonged estrogen replacement therapy and estrogen secreting ovarian tumors increase the risk of this form of cancer. فمثل ما قلنا انه الاكسس of estrogen هو نشوفه موجود at least in some of the risk factors واللي هو نفس السبب في increase the incidence of endometrial hyperplasia فهو نفس risk factor for what endometrioid type endometrial carcinoma. Gross features. Endometrial carcinoma may be exophytic, fungating, polypoid, or infiltrative. So remember, either exophytic or infiltrative. Microscopical features, as we said, we have endometrioid carcinoma and serous carcinoma. Each type has its specific microscopic features. For endometrioid carcinoma, consists of malignant endometrial-like tubular glands of varying grades. Squamous metaplasia is frequent. Sometimes the tumor is adenosquamous carcinoma. So الانdometrioid carcinoma واللي هي اجت تسميتها اصلا ليش؟ لانه it looks like endometrial glands. ممكن نشوف ويا squamous metaplasia وممكن حتى نشوف شي higher اللي هو squamous carcinoma, and we call it adenosquamous carcinoma. Tumors originate in the mucosa and may infiltrate the myometrium and enter vascular spaces with metastasis to regional lymph nodes. The second type, اللي هو serous carcinoma, forms small tufts and papillary arrangements rather than the glands seen in endometrioid carcinoma, and has much greater cytologic atypia. They are particularly aggressive. فنشوف انه عندهم greater cytological atypia، وبالتالي نتوقع انه البيهافير يكون particularly aggressive. This is the gross appearance of endometrial adenocarcinoma. In the upper figure, the tumor shown is polypoid exophytic. In the lower figure, the tumor shown is extensive, nodular, and highly infiltrating. This is the microscopical picture of endometrioid adenocarcinoma. In A, the carcinoma, which is of endometrioid type, it infiltrates myometrium and displaying cribriform architecture. B, which is the higher magnification, reveals loss of polarity and nuclear atypia. This is the microscopical picture of adenosquamous carcinoma. In the upper figure, as you see, endometrial adenocarcinoma of endometrioid type with a component of squamous carcinoma, which is marked by the arrow. In contrast to the previous figure, the squamous component has markedly atypical cytologic features, which is obvious in the lower figure in higher magnification. فتشوفون بالhigher magnification atypical cytological features including high NC ratio, pleomorphism, hyperchromasia, mitosis, very obvious. This is of the squamous component. So this is adenosquamous carcinoma. This is the microscopical picture of serous carcinoma of the endometrium, displaying formation of papillae and marked cytologic atypia. Clinically, patients with endometrial carcinoma present with leukorrhea and irregular bleeding. With progression, the uterus may become palpable, and in time it becomes fixed to surrounding structures by extension of the cancer beyond the uterus. Endometrial carcinoma are usually late metastasizing neoplasms. The prognosis depends heavily on the stage of the disease. Topics for student self-study include: first, endometrial polyps; second, malignant tumors of myometrium of uterus, leiomyosarcoma. Objectives: first, discuss endometrial polyps including pathological features, the gross and microscopical features, and clinical significance. Second, outline malignant tumors of uterus, leiomyosarcoma, including epidemiology, pathogenesis, and pathological features, the gross and microscopical features. In front of you, suggested further readings. I hope you have benefited from this lecture and that you have enjoyed this lecture. Thank you.